right. It's 9 o'clock. I hope everybody can hear me. Can I have somebody raise their hand if you can hear me just fine? Thank you. All right. Well, my name is Lee Johnson. I am the Medical Policy Manager in the Office of Healthcare Policy and Authorization. Our training, I will be going through our training today, the statewide provider training specific to healthcare policy. Our team primarily deals with coverage policy. So as you see in the name healthcare policy, that's what we'll be covering. Specific to this training, for those of you that have attended multiple trainings, you may note that some of the information is being repeated from some of those other trainings since it crosses into other areas. But we just wanted to be thorough, especially for those of you that are attending just this meeting. With that, the information that we'll be covering today is specific to items or policy changes that have occurred over the last year. And these are the more significant policy changes as they relate to manual changes or rule changes. Specific code changes are published in our Medicaid information bulletin, but overall, we typically won't hit or we won't be hitting on or addressing all of those coverage updates as they relate to codes. Only because there's so many of them. As far as questions goes, please hold off on questions until the end. There will be a time for questions at the end of the presentation, and I'm happy to answer those. We may not be able to answer or have the answers to all of your questions, and I'll remind everybody of this at the end, but we will take any questions that we don't have the answers to back and investigate and then respond accordingly. So, all right, so we're at 9:02. We will jump into this presentation here. Again, I'm Lee Johnson, for those of you that joined after I had introduced myself, the Medical Policy Manager on the Office of Healthcare Policy and Authorization. All right, so 2022 Medicaid statewide provider training for healthcare policy. First thing here is this is our agenda. This is what we will be going through, discussing. These are the policy changes to provider manuals that have happened over the past year since last July. But first, before we jump into those, a couple of notes for those of you that aren't aware. The Department of Health and the Department of Human Services has now merged into the Department of Health and Human Services. This went into effect on July 1st, 2022, so fairly recently. But yes, we have merged the two agencies or departments together into one. And then in addition to that, the Department of Health and Human Services is designated by CMS, or the Centers of Medicare and Medicaid Services, as a single state agency to administer and supervise the administration of state Medicaid program. Specifically within that department, we operate under the Division of Integrated Healthcare, and it is responsible for implementing, organizing, and maintaining the Medicaid program and the CHIP program. Okay. All right, so first policy change here, central nervous system neurological assessments. This service was opened up in November of last year, 2021. But specifically, we updated our coverage to allow for brief emotional and behavioral neurological assessments to be covered by Medicaid for EPSIT eligible members. For those of you that aren't aware, EPSIT is typically falls under members that are 20 years of age or younger. There are instances where that isn't, but just think pediatrics overall. Reporting of this service is done under CPT code 96127. You can see the description there. I won't read it, it's rather long. But this is typically used for administering, scoring, and documenting brief behavioral and emotional screenings, including assessments used for depression, anxiety, suicide risk, substance use, ADHD, and other conditions. It is intended for use in physical medicine settings, such as primary care, to screen for underlying mental health conditions. There are limitations to the reporting of these services. Specifically, providers are not allowed to report more than 4 units per member per year, with a maximum of 2 units per date of service. So, next service here, COVID-19 vaccination counseling. Early this year in January, Medicaid updated its policy to allow for coverage of counseling visits in which the healthcare provider discusses the importance of childhood vaccinations against COVID. It is covered by Medicaid and reportable for reimbursement. The reporting of this service is done under CPT code 99401. You can see the description there. And Medicaid requires that you append the CR modifier to the claim line in order for this to be processed. Important note on this is that it is a carve-out service billed directly to fee-for-service Medicaid instead of the member's managed care entity, such as, or for example, Molina, Healthy Use, Select Health. Dental service updates over the past year. First, starting July 1, Medicaid now covers porcelain dental crowns for EPSIT and pregnant members. These services are covered, it says for permanent teeth only. I need to validate that, but I'm fairly certain that's the policy. Dental crown services for aged, blind, disabled, and targeted adult Medicaid members undergoing treatment for substance use disorders continues to be provided through the University of Utah School of Dentistry on their network. And then we listed out the codes that were updated as far as reportability for dental crowns. Okay. Next slide here. Also effective July 1 of 2022, Medicaid now covers posterior resin-based composite restorations for EPSIT, pregnant, aged, blind, and disabled, and target adult Medicaid members undergoing treatment for substance use disorders. This enhances the coverage of available services, where previously the coverage of amalgam fillings for posterior was the only allowed coverage. Now Medicaid covers this resin-based composites. As you can see there, those are the 4 codes related to posterior teeth or back teeth. They align with the amalgam ones, except for obviously it gives providers more availability to report this service in lieu of the amalgam services. Next, Medicaid also began to cover silver diamine fluoride, which is a liquid substance used to help prevent tooth cavities or caries from forming, growing, or spreading to other teeth. Medicaid covers SDF for the treatment of primary dentitions for EPSA eligible and pregnant members. So baby teeth or non-permanent teeth. It is used for the treatment of dental caries and may be applied once per tooth every 6 months. Medicaid does not cover SDF for caries prevention or dental hypersensitivity, which is additional uses for SDF, but Medicaid doesn't cover it for that at this time. Next is an update to and clarification to the Medicaid policy. Denture relines and adjustments when performed by the original provider that made the dentures within 6 months of the member receiving those dentures are included in the denture payment and are not reimbursable separately. So there is a global period with dentures in which all services are covered related to that. After the global period, though, Medicaid will cover 2 relines or adjustments per arch per year. And that information is updated specifically on the code coverage, the reimbursement and coverage code lookup tool that Medicaid has. All right, updates to laboratory services. Jumping in here, laboratory services were updated this year, started in July 1. This included an update to the Hospital Services Provider Manual, Chapter 8-10, and the Physician Services Provider Manual, Chapter 8-11. The update includes information related to claim processing, which requires that providers report their CLIA certification number on their claim. If the claim does not have a CLIA certification number and there is a laboratory code reported with that, then there's the potential for a claim to be denied. So it's important that as a provider, you're reporting your CLIA certification number along with any laboratory codes that are reported. All right, nutritional service updates. There was a few updates here. Specifically, the big one, though, was the clarification for reporting medical foods and enteral formulas for the treatment of inborn errors of metabolism. Information specific to these codes or additional information specific to these codes can be found on the coverage and reimbursement code lookup. And the notes for each of these services has been updated. The following codes are used to report medical foods and enteral formulas for the treatment of inborn errors of metabolism. B4157 is used to report for members that are non-EPSIT, whether it be for oral or enteral administration. B4162 is used for EPSIT members for enteral administration, and S9435 is used for reporting for EPSIT members for oral administration. As a clarification, based on direction from the USDA and CMS, Medicaid serves as the primary payer for medically necessary foods for members with eligibility for both Medicaid and WIC, or the Utah Women, Infants, and Children Supplemental Nutritional Program. Medicaid does require for it to be covered by Medicaid that the member is 1 year of age or older, except for in circumstances where they have an inborn error of metabolism. The Medicaid coverage criteria has to be met, and then a requested medical food must be found on the Pricing, Data Analysis, and Coding, or PDAC. That's provided by Palmetto on the Noridian local coverage determination. And it aligns, that demonstrates if you're reporting a medical food, what is the appropriate HCPCS code to report. Providers should submit requests for medical foods to Medicaid first when provisions listed above apply. Medical food requests that do not meet the listed requirements or non-covered services should be submitted to WIC for coverage. So in other words, if it does not meet Medicaid coverage, then it goes over to WIC. But providers should be requesting these services when a member is eligible for both WIC and Medicaid from Medicaid first. Non-covered services, oral nutritional supplements for adults are not covered by Medicaid, except for with members with inborn errors of metabolism. Enteral formula is not covered for members under 1 year of age, as most enteral products are breast milk substitutes, with the exception, as previously stated, for members with inborn errors of metabolism. Another update is assistance to surgery and the reporting of these services. Specifically, in 2021 legislative session, for Senate Bill 27 modified the Practice Act, or the scope of practice for physician assistant. The bill's establishment helped identify some areas of coverage that needed to be addressed. Medicaid policy did not cover PAs or nurse practitioners as assistants to surgery, which within their scope of practice is permitted. So to align with that scope of practice, Medicaid now allows for PAs and nurse practitioners, non-physician practitioners, to report services as an assistant to surgery. Sorry, excuse me. This is done by reporting modifier or a pending modifier AS, assistant to surgery for non-physician, to a claim. It still requires that the code allows for an assistant to surgery to be a covered service, but they are able to report those services now, where previously they had not been able to. All right, just a clarification update related to physical and occupational therapies. Specifically, this was updated in the provider manuals just to help outline the Medicaid coverage. Physical and are covered benefits for eligible Utah Medicaid members. PT and OT for traditional Medicaid members is covered, is limited to 20 therapy sessions per member per calendar year when criteria are met. So prior authorization is required for more than 20 sessions per calendar year for both PT and OT. Important note here is you get 20 PT and you get 20 OT for the traditional members. For the non-traditional members, though, the PT and OT are limited to 16 total in aggregate per member per calendar year when criteria are met. In other words, in any combination, but they are limited to 16 units, or 16, yes, units, or sessions, sorry, per year. Prior authorization is also required for more than 16 sessions per calendar year. When reporting these services, append the modifiers GT or GO to distinguish between a PT or an OT. Qualifying clinical trials. This was a new policy update that came through this year. Went and updated the state plan to go into effect for 1/1/2022. The other Medicaid policies were updated to follow suit starting July 1. Specifically, this update to Section 1905 of the Social Security Act, titled the Consolidated Appropriation Act 2021, was approved by Congress and outlines the mandated coverage of routine member costs associated with participation in certain qualifying clinical trials. Due to this mandate, the following have been updated. The state plan, which was previously mentioned, the Utah Administrative Rule R41471, which is the EPSIT-related rule, and then the following provider manuals have been updated: EPSIT services, hospital services, physician services, Section 1 general information manuals. All this outlines and points to the primary policy that indicates that, yes, the associated costs related to the clinical trial are covered services by Medicaid. Radiation treatment, delivery, and management services. This policy has been updated to help better guide providers as far as reporting these services. The policy surrounding the reporting of radiation treatment, delivery, and management code was updated to match the NCCI, or National Correct Coding Initiative. Some of the changes follow specifically for CPT code 77385 and 77386, and are to report guidance and tracking when services are performed in an outpatient hospital settings. CPT code G6015 and G6016 are to report guidance and tracking when services are performed in a freestanding non-outpatient hospital facility. So the services are reporting the same service, just where that service is performed. If we could hold questions till the very end, we will allow for a Q&A section, but we will get to that. Please note your question. Next on here, transportation services include, sorry, I read that wrong. We're still on radiation therapy. Radiation therapy services include CPT code 77387, used to report professional services, and must have modifier 26 appended to the claim in order to be reimbursed. Do not report this code on claims with CPT codes 77432 and 77435, since the professional component is built into those services, and do not report this code with CPT code 77371, 372, 373, 385, and 386, as the technical component is included in these codes. The CPT codes 77427, 432, 431, 432, and 435 are used to report professional services and must have a modifier 26 appended to the claim in order to be reimbursed. The Medicaid operating system just requires that occur, even if the service is specific to just the professional component. Transportation services. This year, starting in July, the Medicaid updated its contract or process, with working with UTA. The UTA transit card replaced the paper pass, so now it's a digital tap pass, which is pretty standard for UTA. The UTA transit card is only appropriate when used for medically necessary appointments with Medicaid providers and can be used for either the local bus tracks, street cards. It may not be used though for front runner, ski bus, flex routes, paratransit, or van pool. Questions related to who qualifies for this service. UTA transit cards are eligible. Eligibility follows the same process as member Medicaid eligibility. It is a month-to-month basis with addition of 30-day grace period. If a member is 5 and younger, has a disability that qualifies them for an attendant, they will need to have a UTA transit card to identify attendants who may not be their parent. And then attendants do not need cards as long as they are accompanying a member who is authorized to have an attendant. Additional information on this can be found on the Medicaid website as well. Members who need a UTA transit card after June 24th will be able to request one on the My Benefit Plan page or by calling a health program representative. Have that number at the bottom there. We went through who qualifies. The last bullet there, members who require assistance during transportation for medical reasons, whether physical or mental, may be authorized to have an attendant. So I know to have an attendant, it has to be medically necessary. Cedar City Transportation Services, or CATS, provide NEMT for traditional Medicaid members residing in the Cedar City area. These services include fixed bus routes and dial-a-ride. Dial-a-ride is similar to UTA's paratransit. It is available for those members who are unable to use the fixed routes. It's door-to-door transportation for services that provides wheelchair accessible vans to take the elderly and disabled from one destination to the other within city limits. If a member is needing to gain access to Dial-a-Ride, they must fill out an application found on the CATS website. To schedule a ride with Dial-a-Ride, those are the numbers that can be reached. Weekdays is different than Saturday. And then members will need to provide their current Medicaid ID number when using these services. Hospital claims. Not a lot of policy changes, but there were some clarifications. I'll point out the clarifications versus the policy changes. This one, the inpatient hospital 3-day admission policy, was a clarification to the hospital services provider manual. So it was a policy already in place, but we were just adding additional details for providers. If an admitting hospital furnishes services in an outpatient setting up to 3 days before an inpatient admission, Medicaid will incorporate the outpatient services into the DRG determination for inpatient reimbursement. Medicaid defines this as a 3-day admission policy. An example of this is if a member is admitted to an inpatient hospital on a Wednesday, services performed on the previous Sunday, Monday, or Tuesday would be considered part of the inpatient service. The 3-day admission policy only applies to acute inpatient hospital admissions. Pre-admission services furnished within the admission window that are determined not clinically related to an inpatient admission are not subject to the 3-day admission DRG payment policy. Due to limitations in the Medicaid, due to limitations of Utah's current Medicaid's claim processing system, there are instances when an entire claim will deny as a single denied claim. Specifically, this is reporting related to inpatient services for covered and non-covered services. For example, a claim is denied when a single line is non-covered service. This can occur when a claim is submitted for a service requiring prior authorization, but the hospital or other provider did not obtain a prior authorization. To allow payment for covered services, when non-covered services have also been delivered, Medicaid requires acute inpatient hospitals to submit claims that include covered services and exclude non-covered services that would otherwise result in the denial of the entire claim. In addition, when a claim is submitted that excludes non-covered services, providers must not include any ICD-10 PCS, CPT, or HCPCS or revenue codes related to the non-covered service. So if it's non-covered and it will result in a denial of a claim, leave it off when reporting. Additionally, if an admission to an acute inpatient hospital is primarily to receive services not covered by Medicaid, all services performed for that episode of care are non-covered and will not be reimbursed. This policy applies regardless of whether or not Medicaid would have covered some of the services performed. An example of this would be a cosmetic surgery. Medicaid doesn't cover cosmetic surgeries, but some of the services related to it would be covered by Medicaid. Medicaid would not cover those services because they were related to the primary procedure that is not covered. All right. When reporting claims related to inpatient hospital, so this is related to, inpatient rehabilitation facility claim submission. When reporting claims related to inpatient hospital intensive physical rehabilitation services, providers report using revenue code 0128 on the first line of the UB04 claim submission form to identify the inpatient hospital intensive physical rehabilitation claim. Additionally, providers must make sure that the prior authorization number permitting services is on the claim, and failure to have this revenue code or the prior authorization number, it should be and the prior authorization number will result in a denial of coverage. So you need both elements, rev code 128 on the first line, and then the supporting Utah specific DRG with the prior authorization number. Modifiers 24 and 25. This information was just a clarification to an existing policy. It was enhanced using information from the AMA, American Medical Association, and their coding guidelines, as well as CMS requirements. Specifically, reporting modifier 24, this was updated to include claims submitted with modifier 24 require the submission of documentation substantiating correct reporting of an unrelated evaluation and management service by the same physician or other qualified healthcare professional during a post-operative period and qualifies for manual review. The provider may need to indicate that an EM evaluation and management service was furnished during the post-operative period of an unrelated procedure. This circumstance may be reported by adding modifier 25 to the appropriate level of evaluation and management service. Additionally, modifier 24 is appropriately applied when it is used for anesthesia, pain management services. Service reporting documentation must include when the epidural or block injection is given relative to the general anesthesia. Modifier 25, the information here was added to help clarify. Claims submitted with this modifier require the submission of documentation substantiating correct reporting of a significant separately identifiable evaluation and management service by the same physician or other qualified healthcare professional on the same day of the procedure or service and qualifies for manual review. Medicaid considers an E&M as a significantly separately identifiable service when the provider may need to indicate that on the day of service, the member's condition required an E&M above and beyond the services provided or beyond the usual preoperative and postoperative care associated with procedures that was performed. The E&M service may be prompted by symptoms or conditions for which the service was provided and therefore does not require a different diagnosis when reporting. An example of this is many of the CPT and HCPCS codes have innately built into them a level of evaluation and management, and reporting an E&M beyond that requires the application of modifier 25. Medicaid did update its retroactive authorization policy. This update was an enhancement to allow for more circumstances when Medicaid will take into consideration reviewing a claim for a retroactive authorization. The first is By the way, these changes were made to the Section 1 General Information Provider Manual, Chapter 10-3. The first here is Chapter 10-3.1. If inaccurate information, if a provider can demonstrate that a Medicaid representative or Medicaid website gave inaccurate information about the need for prior authorization, a retroactive authorization may be requested. In order for this to be taken into consideration, providers must submit supporting documentation of the inaccurate information in writing via email, fax, or letter. The documentation must include corroborating information such as this customer service representative's name with the date and the time of the phone call, or screenshots from the website with a timestamp. The OIG completed an audit and found that claims containing procedures that require PA for inmates of public institutions were being forced without a PA in place per an existing Medicaid policy. This internal process was resulting in an OIG recoupment of funds due to not having a PA on the procedures. And so this prompted an investigation and resulted in a need for us to update our policy related to our Medicaid policy in relation to inmates of public institutions. So as a result of the investigation, the following was changed. Circumstance 7, exceptions for inmates of public institutions, was added to Chapter 10-3 to allow for retroactive PA for inmates of public institutions for procedures that require PA. In addition to this, the policy was updated in general for retroactive PA request or retroactive authorization requests. The time limit on that had previously been a 90-day window. It was transitioned to 180 days, and that covers all circumstances under the retroactive authorization considerations. Inmates are not eligible for Medicaid while incarcerated. However, the eligibility lookup tool will indicate that the individual is eligible for Medicaid if they were eligible before incarceration. Just something to be aware of. The prior authorization reviewer will or should verify admission to an inpatient hospital setting, and then they are an inmate before issuing a PA. Before rendering services that require a PA, acquisition of a PA is not necessary for inmates. Medicaid authorizes requests retroactively when services are deemed medically necessary and documentation meets Medicaid policy requirements. The next section that was updated was the members with Medicaid and Medicare, or dual eligibility. Due to the considerable variances between Medicare and Medicaid coverage policy, it can become difficult for providers to know the differences. Specifically, retroactive authorization for durable medical equipment, medical supplies, prosthetics, or orthotics may qualify for the retroactive authorization of services. Medicaid does not make exceptions for retroactive authorization for Medicare supplemental plans. For additional information regarding dual eligibility, providers should see Chapter 11-5.1 Medicare crossover claims of the Section 1 General Information Provider Manual. And to add to that, Medicare crossover claims only apply to Medicare Part A and Part B. No exceptions will be made for Medicare supplemental plan coverage. An example of that would be Medicare Part B. That is not B, sorry, D. That would not qualify or fall under the dual eligibility policy or for crossover claims. Exceeding limitations. This was the final policy update related to retroactive authorizations. Providers may request retroactive authorization when quantity limits are inadvertently exceeded. For example, a provider unknowingly exceeds quantity limits for a previously performed service by a different provider. The new provider should make every reasonable effort, for example, by contacting customer service to determine if quantity limits have been met. Each provider is responsible for checking quantity limits and requesting prior authorization once quantity limits are met. Quantity limits count to the member and are not unique to the provider. Additionally, if more than one request is received for the same item or service, the authorization for the first complete request will be the one approved. Of note, this exception does not apply to pharmacy claims. For information regarding pharmacy claims, refer to the Pharmacy Services Provider Manual. And that is everything on retroactive authorizations. All right, Q&A period. If you do have additional questions before we jump into these related to coverage policy, you can send those questions to the DMHF medical policy at utah.gov email. The medical policy team monitors that email and responds to providers accordingly. Again, those questions are related to healthcare policy coverage. And just as a resource for providers to reach out. All right. I know we had some hands raised during the presentation. Willing to look at questions or. All right, so first one here. Dental Medicaid claims should be submit for covered and non-covered codes separately. No. So the submitting of the covered and non-covered was specific to acute inpatient facilities, specifically standard hospitals, because of the way the system processes the DRG calculations. So T1019s now no longer needed for PA starting on September 1, according to Utah State Medicaid. How are we supposed to track those and have information ready if we have an OIG audit? That is a good question. If you could put your email in there, I think that's a takeaway question that will need a little bit more research. Is that all right if we get your email address? Sharon, what's the standard process for that? Or do we just request their email address?
Yeah, so if I'm fast enough, I'm looking up their email. So I did have hers, but thank you for putting it in the chat as well. So we've captured that. So if I have your email from your registration, then we will use that email. If not, we'll ask you to put it in the chat. Thank you.
Thank you, Sharon. All right. Next question. I know we covered a lot, so just as a recap, I'll go back to the beginning here on the agenda, just to maybe refresh your memories as far as what was discussed. Oops, right here. When will the updated personal care manual be available online? Is that in relation to the July update? Is that question related to that? Sanford, is your question in relation to the July 1 update or the September 1 update for the personal care services?
I guess September 1.
September 1, okay. I am assuming within some time in September, without being overly broad. It's typically mid to late September or whatever month the update's supposed to occur. I know sometimes there's a delay in updating that information, and there's variable factors that contribute to that.
Okay.
Any other questions? If there's not, I think we can conclude this presentation.
Sorry.
Go ahead.
Lee, let me ask one more thing. How about the July update? Is that one, is it up yet? I don't think it's up, is it?
I have not checked this week. I'm actually, if you give me a moment, I can check.
I guess my next question be, is that version finalized now but it just hasn't gone up on the website, or is it still being tweaked?
No, that version is finalized for the July 1. As I'm looking at this, it looks like it's not updated on the link to that manual, but that manual is finalized.
Is it possible to just get a PDF copy of it or something in the meantime, so we can start working on our compliance with any changes?
Let me get your email, and I will look into that just to see what the delay is in that update or publication. Okay. I'm not sure on why, but I'm sure providers are anxious to get that information. And I'm taking a note to do that.
I just put in the chat my email address because it's a little,
perfect.
Sometimes it can be a little tricky. So there you have it. Yeah, we would love to see that.
Perfect. Thank you. We'll get that. We'll get back to you on that.
Thank you. On the 1019s, state Medicaid has started returning our request for prior auths on the 1019s, telling us that we don't need prior auths anymore, and that was news to us, and that's why we're so anxious. I know Danny had asked you about that earlier. We're really anxious to find out what the new procedures are, because it is, it's in effect, I think, on the 1st. So this is really the first we've heard about it, and we want to make sure we're in compliance with whatever the new thing is.
I will need to look into the tracking of the utilization from that OIG audit perspective. I'll get back to you on that portion. I can say though, yes, the September MIB hasn't been published yet, but it sounds like the prior authorization team is already letting providers know as they're requesting those services. So that information hasn't been sent out publicly yet or externally. And so I'll look into those questions though and see about that.
So Lee, I know this is a little beyond what the scope of this presentation was, but in some of the drafts that were going out on that, it looked like maybe there'd be a little bit of expansion for personal care services or for 1021s, maybe into the area of mental health. Do you know, is there going to be kind of a broader scope for people who might be able to qualify for those types of services?
Not that I am aware of, not off the top of my head.
Okay.
That doesn't mean that that's not true. It just means I don't have it.
Yeah, fair enough.
We can look into that as well.
Okay, thanks very much.
Okay. Are there any other questions? If not, I believe we can conclude this training. And thank you everyone who was able to take some time to join us. If you do have questions that you think of after the fact, that DMHF email, DMHF medical policy at utah.gov email, is the best place to send questions related to coverage policy. Okay, thank you, everybody.